Assalamu alaikum. Thank you, Ustad al-Aziz, Dr. Umar. Thank you very much. So this is, we translimbar intraocular delamination during cataract surgery. This is the abstract for the study. And we know that the dense cataract, the problem and the challenge in dense cataract is to assess the macula and the retina. It cannot be assessed fully because of the high density of cataract. So preoperatively is usually incomplete. So what the next step is to do it postoperatively. If you do postoperative assessment after taking the cataract out, there is drawback. Some disorders maybe get worsened or exacerbated after doing cataract surgery, especially diabetic macular edema, retinal vein occlusions, and uveitis. And also, the patient, the expectation of the vision will not go with the patient expectations, because he expects the vision improve to 6.9, but because of the comorbidity in the retina, he will not. And might the patient need other intervention for the possible comorbidity in the retina? And definitely this is not cost effective because subject the patient to another surgery and psychologically traumatizing to the patient. So the best thing is to do, if you cannot assess the retina before doing the cataract, is to do it during the surgery, intraoperative. The normal, this is the background of the study. I've got 42 eyes in 36 patients. This is done in Qatar when I was working there. All the patients, the vision 660 or worse, and the view of the fundus on the major vessels or the disc can be seen. And no way to do the RCT or fundus photo and the B-scan done, but only to see if there's gross pathology in the retinal axis, retinal detachment. But the details of the macula cannot be assessed by doing B-scan. And the patients, all the patients, they consented for doing cataract with the possibility of additional surgery if needed during cataract surgery. The normal way of assessing the retina during the surgery of cataract is doing it in direct ophthalmoscope. But the point with this is the view is limited, the magnification is limited with the 3 times only. You cannot see the minute details of the retina. And the parallax, the inverted image, it might make annoying the surgeons during the surgery. So the best is to use endolight. It costs you only the endoprobe, and you pop it through the side port of the cataract. You are not need to do any extra incision, just the side port of the limbus, and do it just prior to the insertion of the implant. You have to expand the bag with the more viscoelastic, so more room will be can accommodate the insert of the endoprobe and not endangering the posterior capsule. And after this step, just with the view of the vitreoretinal viewing system. I've used one of three, the ReSight for the Zeiss microscope, or EBOS in the von Mueller microscope, and the other one, for payment, that's portable one, can fix to any kind of microscope. And this is the parameters and demographic factors for the patients, all done under topical, and except 6 patients under subtenon. 7 patients, they have previous history of injections, and 16 patients, they got diabetes. And this is the video. It will show how I don't know if it can work here. Yeah. And show how the procedure can be done. Just put this port in from the side. You'll see the posterior capsule not transparent. I will go to this point after. And after that, put the viewing system for the vitreoretina, and you can see the retina in details, and you can control the zoom by the microscope. You can see even the small lesions in the macula, if any. And this I consider as a bridge between anterior and posterior segment surgeries. So you are doing cataract, if you see something, you will do more procedures if needed. All right. The view gain. What is the view gain? By the insertion of endolight through the limbus from the side port, you will see the posterior capsule different from the capsule visualized by microscope only. By microscope, it looks transparent, right? So if I've opened the video, you'll see when I put the light, the capsule looks like not transparent. This is because of direct reflections of light from anterior aspect of posterior capsule to you. So it looks not transparent. It is transparent. And next one. And so the result for this, 8 eyes had additional procedure with the cataract. 7 of them diabetic macular edema, and one of them has submacular hemorrhage, most probably due to AMD. And all of them received concomitant intravitreal lucentis. No complication related to the indelimination has been seen, and posterior capsule visualization was very significantly improved, and polishing done in 6 eyes. And all the lenses was implanted within the capsular bag. So the advantage of this technique, no extra incision needed, just use the side port. Magnification is not limited. You can use the zoom view microscope, unlike by the indirect ophthalmoscope. You have additional view to the posterior capsule. You can, if you are not sure about the integrity of the posterior capsule, you can use this technique to make sure that if you want to implant the lens in the bag or in the sulcus. And definitely you can decide on table if for any further intervention, vitrectomy or injection or laser. And thank you.